Hello everyone, and welcome to a online lecture, as promised, regarding peripheral vascular disease, specifically superficial thrombophlebitis and deep vein thrombosis. We'll approach this lesson as we do any lesson. We want to know what is it, or what's it all about, who's at risk, the signs and symptoms that we got to look out for, how do we diagnose it, definitely how do we treat it, how do we prevent it, even better, and a nursing diagnosis. And the nursing diagnosis essentially is a label that we give our plan of action, or our plan of care. We say, inadequate tissue perfusion, or ineffective airway clearance, etc. It's basically just a direction to follow as I build my plan of care for this individual. So let's start at peripheral vascular disease. Peripheral vascular disease is kind of a newer term. It's more like, you've probably heard peripheral artery disease, and for all intents and purposes we'll use the two terms interchangeably here, okay? So essentially it is circulation disorders that affect blood vessels outside of the heart and brain. Typically it affects the lower extremities, the legs, but it can affect arteries or veins that lead to the kidneys, that lead to other organs, upper extremities, etc. It's caused by narrowing of the arteries or veins due to atherosclerosis, thrombus itself, inflammation, vasospasms, fat emboli, other things of that nature. So it'll cause a partial or total occlusion, which will essentially just cause decreased perfusion to the extremity, causing eventual necrosis. The tissue below the obstruction die due to lack of oxygen and nutrient supply. So we call it ischemia. Alright, so with that being said, let's go on to the next slide here. So we're going to nail down some terms, right? So I've been kicking around a few already that you're maybe familiar with or unfamiliar with. An embolism, a blood clot or a substance such as air, it could also be a fat emboli, etc., that has moved from its place of origin and is causing an obstruction of circulation elsewhere. So something that's dislodged and moves and is causing circulatory compromise. Phlebitis is, like we said, anything ending in itis is inflammation of. This particular instance, inflammation of a vein, which can predispose a patient to thrombosis. A thrombus is merely just a clot. A thrombosis is the formation of a blood clot within a blood vessel. Thrombophlebitis is the presence of a thrombus or clot associated with inflammation. So that you got that inflammation of that blood vessel due to a clot, or a clot, It usually occurs in the deep veins of the lower extremities, but it can be superficial. So peripheral vascular disease, or peripheral artery disease, let's talk about just basic functionality. We know that we depend on venous return, right? So we depend on our gastrocs, or our calves and other large muscles to pump blood and get it back to, in our own heart, to get the blood back to our for venous return. The cardiac output of that reaches us systemically has to eventually go back to the heart. In order for that to happen and to cause no backups of blood and other complications, we need the valves to function properly. So there's valves throughout our entire venous and arterial system, so that when the heart pumps, those valves open, and then when the heart's refilling, they close so that nothing backs up. Okay. So factors that can alter the flow in the veins are thrombus or clot formation, defective valves, inadequate contraction of skeletal muscles, things like paralysis and sedentary lifestyle, or casts that are on for long periods of time, immobilizers, etc. Pressure on a tissue or vein for long periods of time. And so what are the types of DVTs, or peripheral vascular diseases, or clots? There's our superficial thrombophlebitis, and then we got the venous thromboembolism, which are the DVTs and PEs. Some interesting notes on VTEs is there was new core measures put out in 2013 because statistical data was stating that 300,000 new patients annually were being diagnosed with a VTE. Out of those 300,000, 100,000 were dying, or we're having 100,000 deaths each year due to VTEs. So most VTEs are related to preceding hospitalizations within 30 days of VTE event. So that's something to take note of and to ensure that we ask our patients, especially if they're a good historian, they're alert and oriented, that we can ask them, hey, are you a long-haul trucker? Have you been hospitalized in the past 30 days? Do you sit for long periods of time? Other predisposing factors, are you on birth control pills? Do you have a history? We'll get into that more. So the VTE mortality rate is higher than HIV, motor vehicle accidents, and breast cancer combined. So we're looking at a big population here. It's huge in terms of cost and mortality rates. So there's also the factors that affect cost overall are the reoccurrence of DVTs. Once you have a DVT, you're more prone to getting another DVT. And then there's something called post-thrombotic syndrome, which can cause complications and rehospitalizations and cause one to seek medical attention, because if you had a clot for long periods of time, which a lot of times they do, although I mentioned earlier in class that although we have what it takes to break down clots in our bodies, it's a slow process, and in the meanwhile, that clot is a surface that other substances can stick to, whether that's plaque or more platelets or whatever it is. So in that meanwhile, we got to make sure that we're keeping the blood thin, making sure that that we're making sure that thrombus is not exacerbating. But the post-thrombotic syndrome essentially is when you have a clot for long periods of time, it can cause complication a year or more later, because it can present with pain, discoloration of the skin, circulation problems to that area, injury, of course. So, what causes the blood clot to form when it shouldn't? Like, if we have what it takes to prevent clots in our body, why does it happen still? Well, we have something called Virchow's triad. And what that is it's these three criteria, and it's interesting to note you don't need all three, but you need at least two of the three. What does it mean? We need the activation of the clotting system. Hypercoagulability basically is what we need. We need, someone on birth control pills, oral birth control pills, estrogen. We need venous stasis, so those hospital stays, total hip, where we, are in bed for long periods of time, and up to PT very subtly and very rarely. And then, or like the leg in the cast for long periods of time. Injury to the blood vessel wall. So we got a hip injury, right? So we have the injury to the blood vessel wall. We have a hip or femur fracture, where we have the surgical repair, so we're in bed for long periods of time, and your clotting system has been activated, like you're on oral contraceptives or birth control pills. So again, you don't need all three of them. You can have all three of them, but if you have two or more, then you're liable to develop a clot. So what is a deep vein thrombosis? Well, it's the formation of a blood clot within a deep vein, predominantly in the legs. And this is a perfect illustration of what you will see. And I always say that nursing is a game of recognizing things that are there that shouldn't be there. So just looking at the picture, if someone was to present with that same symptom, I might say, all right, maybe we got some contact dermatitis or some cellulitis of just one of the legs. But the first thing I should think about is the worst thing that could be happening with this patient, right? What's the worst thing? Obviously a DVT, or deep vein thrombosis, or VTE. So we're going to ask him certain criteria. We're going to do a good physical assessment. We're going to check distal circulation below that redness, swelling, etc. We're going to talk about the 6 Ps, and we'll go over that in just a second. But right away, when someone presents with unilateral presentation, then we got to think, okay, maybe this is a DVT. So if they have swelling in the right arm or left arm and not in the other one, then we think, okay, what's going on? Swelling. Is it a lymph problem? Is it cellulitis? Is it red and swollen? Is it hot to touch? Do they have fevers? Then we're thinking cellulitis, contact dermatitis, etc. But that's where the assessment and the interview come in, where we say, hey, you have a little scar there. Do you have a PICC line? Yeah, I just had that PICC line removed not too long ago. I had it for, months. And I'm like, oh, okay. So that leads me to think maybe DVT. But always we should assume the worst and roll out the worst and then go down from there. So where does it begin? Where does it end? And this is very important because we got to think, where's it going to end? Where's it going to cause the most damage? And as we know, venous blood or the venous system are vessels leading towards the heart. Okay, they don't necessarily have to be deoxygenated. It just is the direction towards the heart. So if the emboli travels to the right side of the heart, you got to think about the conduction pattern and how circulation works through the heart. The emboli travels to the right side of the heart, and it can go into the right atrium, to the right ventricle, then up to the lungs. Now we've got a PE. If it's made its way to the left ventricle, all the way through the left ventricle, then we're liable to shoot that clot out into the circulating system. So then that might travel to the organs like the kidneys or the liver, the spleen, or the whatever it is. It might cause some compromised circulation to that major organ, or lower extremity or upper extremity, whatever. One of the things that puts us at risk for this is when we talked about atrial fibrillation. And we talked about how when the heart's fibrillating, blood has a tendency to become static and clot. Well, once you create that clot, that thrombus, it's gonna maybe kick in and it's gonna have a good contraction here and there. So then it's gonna travel, outside of the body or to the lungs or wherever it's gonna travel. Okay, so it's just super important to think about where's this thing gonna do the most damage, and what can we do in the meanwhile to kind of control this while we can either they can decide whether they want to do a thrombectomy, take out the clot, or they want to put in a filter to stop the clot from advancing, or if they want to, whatever it is, what can we do at our level as nurses? So what about superficial thrombophlebitis? We talk about phlebitis and we talk about that, no signs or symptoms of infiltration or phlebitis when we document our IVs. And this is important because, even though that thrombophlebitis is superficial, it could still be painful, it could still cause infection, it could still spread, etc. Okay, so we want to definitely look out for these. So phlebitis is the inflammation of the vein in which the endothelial cells, and we talked about endothelial cells, by design they're a non-adherent surface, but due to tissue damage, in this case, why? How is there tissue damage of that vessel? And it's due to the venipuncture. It's due to the IV angiocath. Okay, so we've punctured it, we've got it nice and irritated, or we've damaged it, or it's been in too long, etc. And now it's irritated, it's inflamed, the itis. Okay, and then we got a little clot. All right, it's typically tender to touch, can be very painful, it can be a little warm. And remember that you want to keep an eye on it, maybe draw around it with an indelible marker, make sure that it's an infection that doesn't spread. Also, you might want to put a warm compress and elevate. Where the deep vein thrombosis over on this side is a little different. This is in a deep vein, calf, or in the upper leg here, and it's causing some circulation. So we got normal veins and normal flow here, and the valves are doing their thing. They're allowing blood to pass and then collapse properly. Well, here there's inactivity, so we're not getting that blood pushed around circulatory system adequately. So now we got some accumulation of blood, and it's starting to clump together. Then eventually creates this clot, especially if there's some damage to the vessel here. It has a surface to adhere to. Okay. And then we've got compromised circulation. So who is at risk? Okay, who's at risk? basically anybody's at risk, but some people more than others, okay? We have persons that have injury to a vein, often caused by fractures, severe muscle injury, or major surgery. One thing we got to think about is like the hip fracture or the femur fracture patient. And it's a large bone, so we don't only have to think about an emboli or a thrombosis of blood. We got to think about fat emboli from large bones, you know, so we got a double whammy in that instance. Severe muscle injury or major surgery. Slow blood flow, often caused by confinement to bed, limited movement, the cast that I mentioned earlier, the injured bone, the immobilizing device, crossing legs, sitting constantly with crossed legs and you're at a desk the whole time, paralysis, traumatic spine injuries that would cause you to be paralyzed, etc. That's why it's important when someone's confined to the bed that we still do range of motion exercises. We might engage a venous plexus foot pump, which kind of like, you know, dorsiflexes and plantar flexes the foot to kind of engage those gastrocs and get blood flowing. Increased estrogen, often caused by birth control pills, hormone replacement therapy, sometimes used after menopause, or pregnancy for up to 6 weeks after giving birth. So we have this, like, you know, this would be the instance in the Vircho's triad where we've kicked on the hypercoagulability, okay, and so that we got to watch out for these things. Certain chronic medical illnesses such as heart disease, lung disease, cancer and its treatment. So heart disease makes sense. The AFibs, the inadequate pumping mechanisms that are causing the blood to stay static. Lung diseases with narrowed pulmonary vessels, cancer and its treatments, inflammatory bowel disease, which we don't talk about too much, but yeah, that can cause DVTs to happen as well. The irritable bowel syndrome, IBS or irritable bowel diseases, is a umbrella term and it includes Crohn's disease or ulcerative colitis. Other factors that increase the risk of DVT include previous DVT or PE. So if you have a history of it, chances are you might get it again. Family history of DVT or PE. Age, risk increases as age increases. Obesity, there we see obesity again, and that adds to the probability of you getting a DVT. A catheter located in a central vein, inherited clotting disorders, and that's something we don't talk about too much, but the PICC line and the central lines, that's why they have, every once in a while they have to go in and get their lines flushed with heparin. Definitely we're doing it with normal saline while they're in the hospital, and we might have to do it with heparin depending on the protocol. So when do we think DVT? What are those assessment findings, subjective and objectively? So what does it mean, objective assessment? It means what do you see on the object? What do you see on the patient? Or subjective data. What does the subject tell you? What is the subject complaining about? Well, the objective data is calf or groin tenderness and pain. That could be the same in like the brachial area of the arm. It could be flank pain if it's near the kidneys. It could be just pain. Sudden onset of unilateral swelling of the leg. That's one of the classic signs and symptoms is unilateral presentation. Again, it might be contact dermatitis, it might be cellulitis, it might be something else. However, we got to think about what's the worst thing that might be happening with this patient. What can I do about it? Positive Homan sign. So they're laying in the bed and you kind of press on the sole of their foot, you know, kind of press on their foot and push their toes towards their head or towards their body in that direction, and if it elicits a dorsiflexion, a pain elicited by dorsiflexion, it might mean that they have a positive it means they have a positive Homan sign, but it's not necessarily reliable. But it could be one of the things collectively that kind of makes you think, okay, well, now we got to start thinking about DVT. Let's start with, why don't we suggest to the doc when we give our S-bar on the R recommendation, hey, well, doc, you know, he has unilateral swelling, he has this and that, etc. Positive Homan sign. Why don't we start with a D-dimer, you know, instead of cooking them right away in the CT scanner. We want to compare the area described as painful compared to the one that's not. looking for changes, signs, difference in color, etc. We want to gently palpate the site instead of like getting in there deep and with, we don't want to like massage the area because you could dislodge the clot potentially. We want to look for induration along the blood vessel, warmth and edema. Redness may or may not be present, just like on the picture, but again, the classic and telltale sign of a DVT might be that unilateral swelling. One thing also we want to look at is the 6 P's of ischemia. So what are those 6 P's? They're all right here. There's the polar, or it's actually called poikilothermy, which is basically coolness of that extremity. Pallor, which is the whiteness or paleness. Pain, pulselessness, a weak or absent pulse. Paralysis, or the inability to move, like when you lay on your hand for too long and it falls asleep and you don't have control of it. Paresthesia, okay, or tingling, okay. So these are all collectively some objective assessments that we definitely want to look for. We also want to look for, cap refill less than 3 seconds, sensation intact, that pulse. The subjective assessment, what is the subject complaining about? A dull ache in the calf that may worsen with ambulation, and that's essentially that's eliciting a Homan sign because you're doing plantar flexion and it's causing the gastroc or the calf muscle to engage, and you might feel the pain that way. Legs feeling heavy or tight. If you notice leg swelling and or tenderness to touch, and they're saying that it's painful, or it might be warm to touch, it might be tight, etc. So there's some model predictives of deep vein thrombosis that can be found on IGI 2016, page 730. And these are a point system. So a point or a score of 2 or more indicates that a DVT is likely to occur. So each of these criteria, this is a little misleading, is each of these criteria are worth 1 point here. Okay, and there's also like on this clinical predictive model, there's also something that I don't think IGI added, and it's a alternative diagnosis. Being likely will give you a -2, but I mean, for all intents and purposes, this is a good model. So you get 1 point for this, 1 point for this, 1 point for this, 1 point for this, and if you have a score of 2 or more, it indicates that a DVT is likely to occur. So you can look at the criteria and immediately see if you have active cancer, paralysis, or casting of an extremity, bedridden for more than 3 days, major surgery, etc., then you're likely to get a DVT. So we talked a little bit about diagnostic studies, so in making a recommendation during the SBAR. We don't want to go most invasive or the most risky procedure first, which in this instance would be a CT scan. Now, would it be warranted if they were symptomatic and it was looking like it was turning into emergent condition? Absolutely. If they had a PE and they were had some cyanosis going on, increased respiratory distress, some other telltale signs that would indicate a PE is going on, we're going to go straight to the CT angio, right? But if they're not, and you're able to take this patient in, recognize that something might be happening, it could possibly another diagnosis. However, your gut's kind of saying, I don't know, man, it might be. Let's at least start with the D-dimer level, right? A D-dimer will be the evidence of broken down clot material that's found in the body that we can track with this blood level, right? So if there's evidence of broken down clot after a certain level, so those levels, if elevated, really are the presence of the clot that is degraded by fibrinolysis, okay? And so a positive D-dimer would definitely clue us into it. Now let's take the next step up and get that CT and that ultrasound. But a negative, sources are saying that a negative predictive value of approximately 95% for the exclusion of acute pulmonary embolism or deep vein thrombosis when there's a low or moderate pretest PE probability. Basically, it's a normal, typically D-dimers can kind of rule out that first step, you know, and say, yeah, you know, if there's no presence of that clot degradation, then chances are there's no clot. And the doctor might still order that CT, but chances are he'll say, okay, I think we're pretty good. Let's explore the you know, contact dermatitis or cellulitis or the other things. Or he might just say, well, let's do an ultrasound, you know, something less prone to produce so much radiation. The ultrasound Doppler flow studies, venogram, the plethysmography, impedance plethysmography, MRIs, and if that's the case, if they see those things, then that's when they might want to think about, what are we going to do about it? Are we going to do some surgical management, a thrombectomy, where we ectomy means removal of, so we might want to go in and directly take out the clot, or we might do a filtration, like inferior vena cava filtration, or filter. You've heard of having the mesh or the filters put in certain vessels. That way the clot doesn't advance. Okay. So the treatment, we just talked about a couple modalities there, but there's some drug therapy on page 732 and 735, and a lot of it has to do with anticoag. So like we're saying, we have the ability to degrade these clots with fibrinolysis by our own bodies. However, in the meanwhile, we're going to make sure that clot isn't becoming exacerbated or worsened or bigger or growing in size. So we're going to use maybe unfractioned heparin, oral anticoags like warfarin, low molecular weight heparin like Lovenox, right? So please do look at that drug therapy. And whenever I say look at that drug therapy, it's important to notate, you know, what is it? What's its targeted therapeutic effect? What is it used for? Onset peak duration, so we know what to look out for, when to look out for it, and when we can expect results. Adverse or therapeutic. Adverse reactions, absolutely. Like, I mean, the resonating theme here would obviously be bleeding, guys, right? So if you're on warfarin, and we know with warfarin or Coumadin, warfarin, the thing we're looking at besides PT is the INR, the international, the INR. So think international war when you think warfarin. And you know that the targeted therapeutic range would be between 2 and 3. And let's say it's like, you know, close to 5, you know that we're going to have some bleeding issues. So we got to start thinking about things like that. Or, you know, like we got the special considerations or nursing implications, like how green leafy vegetables can affect, you know, your clotting times and cause your coagulability. So you want to stay away from increasing your green leafy vegetables. You want to, you know, look for signs and symptoms of bleeding. You want to instruct your patient in terms of education purposes. Hey, let me know if you start getting spontaneous nosebleeds. Your gums start to bleed real bad when you're brushing, things like that, you know. Let's see, other alternatives to heparin are bivalirudin, Angiomax, much easier to say, and Reflutin. There's also direct thrombin inhibitors, which are argatroban. Alright, so again, whenever I mention these meds, it's worth a shot to look it up. Just look at the basics. Just, you know, it's very flashcardable to pull up those meds. What do they do? How do they work? Onset, peak duration, side effects, nursing implications. Okay? So again, with DVT, really prevention is the key. So you want to, if you know you have those criteria or you're on that predictor scale, you realize, you know, man, you know, my mom had a DVT and, you know, I just came in for a femur fracture and my leg is casted for a long period of time. I probably want to get off that oral contraceptive and I want to make sure that I have adequate hydration, again, because hydration is key to optimal functionality of the body in general, but again, with filtering, with keeping that integrity of the vessel walls, with perfusion, circulation, and volume. I mean, it just has countless medicinal effect in terms of hydration. We want to exercise the legs during long periods of bed rest or sitting, and maybe if you're doing home health, you might want to think about your patient that has paralysis or some immobility of the body part or the body in general. We want to try to see whatever exercise we can do in range of motion. We want to engage that regularly to ensure that we're getting good circulation. Early ambulation, that's why nowadays whenever you have a surgery, it seems like they're getting you up and at them immediately, which is crazy, but a total knee and you're walking the next day. But really early ambulation has shown really solid evidence that it prevents DVTs, it helps with the recovery, and definitely want to think about elevating the extremity when in bed or rest. We want to do graduated compression stocking, so we don't want to throw those on. It would be just like massaging it right away and dislodging that clot. So we want to talk about incorporating that stuff slowly, like this SCDs. Intermittent pneumatic compression. Venous plexus foot pump. Again, it's the little foot pump that will engage the gastroc and get some venous return going and flow going. Anti-coag therapy, and we want to monitor for complications of PEs. So that concludes my lecture on VTEs. If you have any questions, please don't hesitate to email me. Watch this a couple times. Again, this is the meat and potatoes, but it's worth breaking open in your Iggy book and other resources to try to own the information a little better. Thank you so much.